Welcome to Continuing Medical Education for Emergency Medical Services Providers. This is Left Ventricular Assist Devices, Part 3, Considerations for Emergency Medical Providers.
In this section of the talk, we're going to talk about the specific considerations the LVAD patient prevents for emergency medical providers. Normally, before patients go home from the hospital, both ambulance services, emergency departments, primary care physicians, local fire departments, utility systems should be notified of a patient's impending discharge. Training is available from either the implanting center, the websites related to the LVAD systems, a very common one being thoratech.com or jarvicheart.com. Companion education is actually extremely intensive, and all patients are trained in their device and have families or friends who are trained and able to resource and operate the systems and respond to emergencies should they occur. Every patient should have on them either a binder or some form of jewelry or numbers attached to the device itself that show you the 800 number to call should there be any emergency and you need to talk to a coordinator right away. The normal exam of a VAD patient, there are some things that are different than a normal exam of a person that's using their own heart to keep themselves alive. The things that we look at is first, what does the patient look like? A patient on a VAD should not exhibit signs and symptoms of heart failure. They should be breathing normally, have good color, should be free of the edema and failure findings that you'd find in someone else who's suffering advanced or late stage heart failure. The other two findings that are important is first, it is extremely normal for the patient to be pulseless, meaning they would have no radial pulse, no brachial pulse, may just barely have a carotid pulse. The other finding is instead of heart sounds, there'll be a constant noise heard where the heart should be, and it'll sound as a high-pitched, high-whirling motor noise. And you can hear this if you listen right where the apex of the left ventricle should be, and you'll find, you should find that pump noise right there. The other thing that you'd find in examining the patient is the drive line. The drive line usually exits the left lower quadrant of the abdomen. This should be free of bleeding, signs of infection, drainage, or odor. And then lastly is actually the equipment. The equipment should be normally operating if plugged into either the power of the batteries or the AC adapter wall unit through the power module. And the most important finding is that the green light is on, steady, and the controller is not alarming or making any noise. Secondary assessment of these patients include the absence or presence of fever, states of infections, have they had bleeding loss or gain from things like kidney function impairment or gastrointestinal bleeding, have there been recent medication changes done by the physicians that may change or increase or decrease their blood pressure, the state of their anticoagulation, any rhythm changes, or any metabolic or embolic events including hypoglycemia or pulmonary embolism or stroke. Simple troubleshooting related to the system includes recognizing what level of alarms may be occurring. A system advisory, the lower level of alarm, will be represented by the green light blinking and the machine making a beep per second. A hazard alarm or a higher level of alarm will be a continuous tone and the red broken heart will be lit on the system controller. In both of these situations, you need to check all your power connections, switch to an alternative or replacement power supply by either changing the batteries or reconnecting the patient back to their power module and wall power, check the connections between the system driver and the patient's lead that goes inside their body, and listen to the pump noise to determine if the pump is on or off. If the pump is off, check the patient's vital signs and call the support team as soon as possible. Examples of the lower level of alarms, the system advisories, include lower speed operation of the pump, low voltage advisory, a disconnection of one of the power cables, which is a normally occurring alarm if you were to change power supply between battery to AC power, the need to replace the system driver, or the internal alarm of the driver cell battery is low. Most emergency calls for patients do not involve the left ventricular assist device itself. They can be altered mental status calls, respiratory distress, or traumatic injuries of the patient. Utility emergencies and community-wide emergencies can affect these patients. However, pump failure, cardiac arrest of the patient may actually occur. Common specific medical emergency calls include respiratory distress from pneumonia, pulmonary embolism, complications of blood thinners including nosebleeds, gastrointestinal bleedings, or metabolic emergencies like hypoglycemia. All these events can be treated according to local protocols. Non-cardiac events, the patient should be treated as a normal patient. The VAD coordinator should be called, follow treatment guidelines, consider the strength and level of anticoagulation the patient should be on, keep the support person with the patient at all times, and bring backup equipment including the batteries, power module, and a spare controller. Some cardiac-related events can still occur in the patient even though there's a left ventricular assist device, the most common being an arrhythmia. Patients may have ventricular tachycardia, VFib, or asystole and may be asymptomatic or mildly symptomatic. Their often complaint is the occurrence of ICD or implantable cardiac defibrillator shocks associated with those arrhythmias that may cause the patient to have lower flows or some right-sided failure symptoms. The one thing EMS and emergency medicine providers have to realize is most common therapies to mitigate these arrhythmias may actually not work because of the large, scarred, poorly perfused heart that the patient has.
The recommendations for treatment of LVAD patients with an on and functioning pump who present with ventricular fibrillation, ventricular tachycardia, or asystole are as follows. If the patient is asymptomatic or mildly symptomatic but has evidence of adequate perfusion, the patient should be transported and monitored closely for deterioration or signs of poor perfusion. There is no need to treat the arrhythmias in these patients. If the patient is experiencing repeated activation of their ICD, it would be appropriate to administer pain medications or mild sedation if the patient's condition permits and in accordance with local protocols. If the patient has evidence of poor perfusion, such as altered mental status or cyanosis, it would be appropriate to treat these patients' arrhythmias according to standard ACLS guidelines and local protocols, with the understanding that those standard treatments are not likely to work. In any event that a patient requires defibrillation or cardioversion, whether the LVAD pump is functioning or not, it is okay to use external defibrillators on these patients. Standard apex sternum or anterior-posterior pad placement is acceptable. Remember that the overwhelming majority of these patients will have an active ICD, so if it's visible, appropriate care should be taken to avoid putting the pad over the ICD device, as would be the case in any patient with a pacemaker or ICD.
The setting of right heart failure may be progressive and occur related to either valvular disorders or volume overload, or the pump speed is set too high. Other pump emergencies can include hypovolemia due to secondary causes causing the left ventricle to be underfilled and not enough blood flow available for the LVAD to pump. Additionally, during states of other diseases like infection or sepsis, the body does become prone to making clots or hypercoagulable and can actually predispose the patient to forming a clot in the pumps during states of stress or infection. Other pump-related events include loss of power, failure of the controller, or a fractured or broken driveline. During all of these simple steps of checking connections, checking power, and replacing the controller should be followed. In the event the pump does not restart after changing out the controller, the patient's pump should be deemed to be off and traditional resuscitative methods should be taken place. With special consideration, the chest compressions of the patient may cause structural damage to the heart. In the event that you find yourself treating a patient with a stop pump, you would know this by the fact that the system controller no longer had a green light and you can no longer hear pump noise. The first thing to do is acknowledge the pump is no longer a choice for the patient after trying to reestablish adequate power and changing the system controller. If there's no VAD noise and no pulse, then proceed with CPR and resuscitation efforts as you normally would. If there is a blood pressure, but the blood pressure is not enough to sustain adequate circulation, treat the hypotension and low cardiac output by using drips like epinephrine at the inotropic dose of 0.01 to 0.04 mics per kg per minute. Once they're at the hospital, another important thing to consider is these patients still have the pump in place. The pump may be able to be restarted, but not if it actually develops a clot in it during this time. So the administration of heparin at a dose of 100 units per kilogram IV push would be an important consideration in anticoagulating these patients right away. Milrinone and vasopressin or phenylephrine drips to maintain adequate mean arterial pressure. An emergent echo to assess cardiac function, and if possible, an intra-aortic balloon pump would help sustain circulation. During utility emergencies, patients can have up to 36 hours of power at the time of the emergency, even if they're not prepared for it. They can obviously shelter in place for an extended period of time if they can charge their batteries. They should, however, not be sleeping on batteries. They can be removed to shelter and power. There are no special requirements for the power module, and if they are, they should bring all equipment with the patient. During utility and storm emergencies, an important thing to consider is communication will be difficult, and if possible, the patient should contact their heart transplant center and let us know that they're okay. When transporting an LVAD patient, the coordinator will and should have spoken to the patient and EMS prior to their arrival. The support person should be kept with the equipment. Anytime the patient travels, they should travel with 2 spare batteries and a backup controller. The 800 number is always available for questions. All patients will likely be transported directly to a VAD unit instead of the emergency department at a VAD hospital, and all VAD patients can fly. If your local ambulance cannot travel the distance to a transplant center right away, transfer to either the local emergency department or the interface with a VAD-capable ambulance is possible with many heart transplant and VAD centers. In the setting of a failed device, I do want to review the dose of heparin at 100 units per kilogram IV bolus and the administration of inotropes of epinephrine or milrinone to support the low-output cardiogenic shock, and the addition of vasopressor or phenylephrines to support hypotension. To review first responder skills, you should be able to, at this point, tell us how do you tell if the pump is on. The answer to this is a green light and the sound of the pump noise. How to assess adequate states of perfusion, that is adequate capillary refill, mentation, and skin color. Basic troubleshooting includes checking connections and the power source to the system controller and contacting the VAD coordinator using the 800 number. In the event of patient evacuation or relocation, you should bring as much power as possible and all the patient's equipment. In summary, these patients are common, active, and mobile independent members of the community. There is no palpable pulse to the continuous flow LVAD patient. Their normal pressure is a continuous 70 to 80 millimeters of mercury. They're on usually aspirin and anticoagulants. Arrhythmias are common in these patients, but likely not clinically relevant. And the driveline is the most common problem area of either infection or wire fracture from wear or breakage of the system.